Mamoun, are you ready?
Yes.
So, welcome to the last session. The first talk is with debate between Dr. Mamoun Al-Basheer and Dr. Hazem Habboub about the need for revascularization in the periphery. As we are very late, I'm going to ask you to stick to time and speed up if possible. Otherwise, we're sleeping here. What? Full time till tomorrow or till tonight? So, Dr. Mamoun, when you're ready. Dr. Mamoun is consultant peripheral vascular disease surgeon.
Well, first, thank you very much for the organizers giving us this opportunity. The organizers, and Mahmoud specifically, think of us as the icing on the cake when we talk about the vascular session. It's usually right at the end. We do think of ourselves as the cake itself, so this is probably the last time we're going to participate in something which happens an hour late. And I'm glad that for all the cardiologists here, your science is so much better than your timekeeping, because you haven't been doing a great job with the timekeeping. So the debate, we're going to be quick, Hazem and I. This is a very interesting topic, and the debate has rules. I know in cardiology there are very few debates, and the rules are not well established. But there's a motion, and this is the motion, that Claudicants should not have revascularization procedure. I'm going to be arguing for the motion for 8 minutes. Then Dr. Hazem, my good friend, will be arguing against the motion for 8 minutes. Our rebuttal for 2 minutes, and here rebuttal for 2 minutes. And if there's anybody interested, then we might have one question. We'll vote on it, and maybe the best man win. So the motion is quite interesting because it says claudication. My 8 minutes started. Claudicants should not have revascularization procedures. That's what I propose. Sorry. So it comes from bitter experience for me that I've learned this lesson, that you shouldn't do anything to claudicants. And I strongly believe in that. I do not think you should touch claudicants. And I'll tell you a brief story. About 24 years ago, I was just starting in my vascular fellowship in the Royal Medical Services. And there comes a patient. Both Hazem and I have been partners in crime in treating him. Hazem might not remember him, but I remember him very well, because he's one of those few patients that impacts your practice forever. This is a 60-year-old gentleman who came in walking into the clinic, and he complains of claudication at a distance of about 200 meters. The gentleman complaint been happening for about 6 months. He's sort of non-smoker, diabetic, hypertensive, and it's been bothering him. I was new in vascular surgery, so I thought I'll ask my senior. I asked my senior, and he said, well, if it's too much for him, and he lives in another city outside Amman, do admit him and we'll do the investigations. In those days, we did not have a massive practice in vascular surgery in the Royal Medical Services. I did. We admitted him. Next day, how are you feeling, sir? And he said, the claudication I don't like it. And I went and sought advice. What should we do for him? We imaged him, of course. He had a popliteal lesion, popliteal artery stenosis, significant stenosis. And the advice was, let's do an angioplasty for him. Hazem just came back from the US a year prior, and we were very keen to do a lot of interventional procedures. And we planned to do an angioplasty for this gentleman. We did the angioplasty, and because I was so keen, I stayed for the angioplasty. So I was in the suite with Hazem. During the angioplasty, we had a bit of a complication. His artery occluded. He had thrombus. We ballooned it. It trashed everywhere to his tibials, which were patent before. And you were suddenly in that situation of limb salvage. At those days, the only thrombolytic agent we could use was systemic streptokinase. We used it on him. He started bleeding from his groin. We stopped it. We brought him back the next day, tried to do a bit more. Now he's more ischemic. We took him to theater. We did a bypass. It occluded. Day after, he's even more ischemic. 3 days from the onset of this adventure, he lost his limb. He had a below knee amputation. And the gentleman, when he was discharged, he called me to talk to me. I was a junior surgeon just starting, and I was junior in rank as well. And he said, he was a very wise gentleman, and he said, Doc, I want to give you a piece of advice, which is nice to have advice from patients. I'm not going to go through these slides. I'm just going to tell you stories. And he said, next time somebody like me comes walking into your practice, do not push him out in a wheelchair. And I took it to heart. Since then, I've never, myself, when I became the decision maker, I've never intervened on a claudicant. And there's a reason for it. Because the natural history of the intermediate claudication is not a disease. Claudicants do not suffer because of their claudication. They suffer because of their hearts. Most of these people, if you look 5 years down the line, 75% of them will have a coronary episode. The mortality is high because of their heart. It's a marker of disease. It's not a disease itself. It's a lifestyle condition. And that's what's been happening in vascular surgery for 30 years, where they've been changing the parameters and the indications for intervention on claudicants. Claudication happens from more than one site. The only exception to the rule and to the advice I'm telling you is iliac claudication. In iliac lesions, I'm with intervention because once they occlude, they cause further problem. It's not just a lifestyle modification. But infrainguinal claudication, to me, is a benign disease that has conservative therapy and should never be intervened upon. And the reason why? Because the history of this disease is so much different than CLI and all other vascular problems. It almost never threatens your limb. In one of the slides, oh, by the way, I was teasing my friend Hazem. In those days, you know, if you're, like the saying goes, if you're a hammer, everything looks like a nail. And we definitely were hammers at some stages. And Hazem is so skilled, he will nail anything. But I'll tell you, when you look at the interventions for claudication, you can see that whichever means you use, be it conservative, stenting, or surgery, you're always doing better with doing nothing, with doing the conservative measures, the exercise, the medications, etc. Interventions, in my opinion, are harmful. And the treatment approach to claudication has changed over the last 20 years, where they started talking now about debilitating claudication. Before, it was life-limiting claudication. Now it's debilitating one. And I don't think it's ever debilitating. If you can get somewhere, you can always do exercise, and you do medications, and you take some pills, and makes you a little bit better. But at the risk, you avoid the risk of losing your limb or part of your limb. And I run through this. The evidence for intervention on debilitating claudication has been very limited over the years. And I'll run you to the slide which will show it most. By the way, medications like statins even, improve claudication so much better than intervention. And we have a group of interventions at our disposal that we can use to treat them. But look at this slide, and this is a very important one, because it comes to the conclusion that most interventions on IC, on intermittent claudication, resulted in less than 50% improvement at 2 years. And you carry all the risk from these interventions. In fact, your rate of limb loss increases if you get a fembob, a prosthetic fembob for claudication. At 5 years, you're more likely to lose your limb if you had a femoropopliteal bypass for claudication than leaving it or doing an endovascular procedure, especially with the prosthetic grafts. So the rate of complications that we subjecting our patients to, including an increased rate of limb loss from 4 to 7% at 5 years because of the intervention, is unwarranted and shouldn't be done. In conclusion, and I'm rushing through this, interventions on claudicants have complications and they increase the rate of limb loss. Claudication is a lifestyle condition and non-interventional measures are an effective treatment. Hamati Saltiya and usually says when she wants something not to be done, دشر هالقط. I'm telling my friends and colleagues, please دشر هالقط. Do not touch claudicants. And I always finish by the quote, from a prayer from Sir Robert Hutchinson, from inability to leave well alone, from too much zeal for what's new, from treating patients as cases, from making the cure of a disease more grievous than its endurance. Good Lord, deliver us. Thank you. Hazem.
Thank you, Dr. Mamoun. Very nice talk. Dr. Hazem, answer that one.
Thanks. Well, I'll be with the motion for the okay. Claudicants should have revascularization procedure when it is proper. I'll just quote the same slides. Still, in a recent review from Aberdeen, almost the complication rate of intermittent claudication and the mortality is noted to be the same, even in this slide that Mamoun showed. But we are coming now to a term of disabling claudication, which is a claudication with worsening, decreased exercise tolerance, and claudication that interfere with the lifestyle, and this is very important. And now, in the last NICE, National Institute for Care Excellence, it advocated that preferred treatment depends on many variables now, especially for this group of patients that they have the disabling claudication. And we know from the slide that Mamoun showed, about 30% of the patients, they are going to progress to disabling claudication. Probably like 10% they will progress to critical limb ischemia. So by this, we know that most of the people, they are going to have some sort of lifestyle limiting activities because of claudication. And why is that? Because claudication is not one spectrum. It's a very wide spectrum, and it involves, you might have a Leriche syndrome, or you might have just a focal lesion, and patient comes with intermittent claudication. And if we want to compare both groups, beside having the standard home therapy measures, which is the exercise, the healthy food, healthy diet, stop smoking, and then the medication, blood thinners or statins, etc. in both groups, if you want to come to the recent data, because till mid-2000, 2005, 8, till 2011, all the guidelines, the SVC, the ESVS, it said that for claudication, the best treatment is to do a supervised exercise therapy only. But these things have been changing over the last 10 years. Why? Because there is more data coming out. If we want to compare exercise therapy and progression of critical limb ischemia, this is a nice paper in 2007. It followed up 250 patients with underwent exercise therapy. It was not a supervised exercise therapy and the risk factor measures for 6 years. And they found that the rate of progression of IC to CLI, critical limb ischemia, was almost the same as the group that they have intervention. It's about 16%. For the revascularization procedure, they also had a randomized larger group patients, more than 1,100 patients, underwent revascularization and the follow-up of 2.5 years, and it shows almost the same rate of complication and progression. Data before 2010 was showing a higher rate of complication of endovascular procedures, but the recent data, they are showing they are comparable or becoming even less now because of many factors. So we cannot stick to the guidelines of 2005 to 2011 now. What happens also, and what is very important, is that the failure rate of the not doing anything. The failure rate of exercise therapy was found to be very, very high, almost 45 to 55%. So half of the patients, they fail exercise therapy, which is exercise for 2 years. So most of them, they are non-compliant. And you cannot leave a non-compliant and you know the disease is progressing. And the disease is going to be, in more than 30–40% of these patients, they will end up with critical limb ischemia. So what to do? To stop? Of course not. The other paper is a very interesting paper, was the success rate of conservative therapy. The success rate of conservative therapy was only 70% by maximum. So at least you have half of the patients, they will be non-compliant and they will not benefit. And then you have about 25%, quarter of them, the treatment won't be successful and they are going to proceed to critical limb ischemia or to amputation. And it shows that for the success rate, the average, it took very long time. It took at least 3 months for having an improved walking distance. And the recent studies in the circulation after 2011, it shows that it has shifted. The graph that Mamoun showed that exercise was better than stenting or endovascular therapy has shifted that patients with endovascular treatment, they have now changed in the community walking distance. The claudication onset time is much better with endovascular treatment. And all the data shows there is improvement in the group that they are undergoing procedures. Why is that? There's a lot of factors, mainly because of experience in patients doing endovascular procedure in the last decade. Okay. What's happening also recently in the last 5 years, there are 2 trials that they have changed or geared the practice of treating patients with intermittent claudication. The ERASE trial is a trial that randomized patients allocated for endovascular treatment plus supervised exercise versus supervised only. And the primary endpoint was the maximum treadmill walking distance. And they found a great difference in patients who underwent endovascular therapy plus supervised exercise, almost double the walking distance achieved. And the conclusion was that among patients with intermittent claudication, after 1 year, a combination therapy has an improved outcome in the walking distance and even in shifting into a critical limb ischemia. The other one is this review in the 2019. It supervised exercise therapy, with revascularization. 474 patients, almost half and half medical therapy and supervised exercise therapy and endovascular, and the primary outcome was the freedom from the additional intervention, but the secondary outcome, which is critical limb ischemia or improvement in the maximum walking distance, was much higher in the revascularization group compared to the SET group. So we know that the European and United States guidelines still they advise that standard or supervised exercise therapy is the first method of treatment as a cost-effective treatment. However, they say it takes time, the motivation and the compliance is poor, and because of this, now they advocated that endovascular treatment should be added to patients with exercise therapy. And this has been taken by the NICE. NICE, which is it controls the practice and the guidelines in UK. Now it indicated the endovascular procedures in patients in intermittent claudications under these terms: predicted or observed lack of response to exercise therapy. If you notice that, then you need to do endovascular procedure, presence of severe disability, or presence of other diseases. In this group of patients, endovascular treatment should be considered as also a first-line treatment beside the exercise therapy. And even the SIR guidelines, which is the American Society of Interventional Radiology, have in 2021 have changed the guidelines is that treatment of intermittent claudication should include exercise therapy, drug therapy, and selective revascularization. And this is a practical case. This is a guy
Dr.
that we
Hazem,
did.
Hazem, we have to.
All right. We did yesterday. He's 56 male patient. He underwent exercise therapy for 2 months, but he failed that, and he had just a total occlusion of his SFA. His claudication was due to the stenosis of the collateral, and SFA was dilated, recanalized, and the patient, he is now very happy. I just have a phone call from him today thanking us for doing the procedure. So it's your choice if you want to have an intermittent claudication and keep feeling like this or like this. I would prefer to be feeling like this, Mamoun, running happily and running my goals with no pain, doing an endovascular procedure. This is Mamoun trying to explore the secrets of life in the tombs of pharaohs. If you want to achieve this, you have probably to consider doing an endovascular procedure.
Thank you. Very nice presentations. I have a few questions from the audience. We'll do it quickly, yes? Go ahead.
In summary, according to guideline, management of, just a few words about management of peripheral disease. Claudication without resting pain, medical therapy. Claudication, resting pain, and temporary neurological deficit in a sort of sensory or motor, in addition to medical therapy, endovascular intervention. Claudication, resting pain, and gangrene, surgical interventions.
Thank you. I guess from what Dr. Mamoun said, proximal iliac disease, you should go ahead and revascularize. Dr. Hazem advocates even more peripheral. That's a summary of both talks, if I understood right. So what should we have a vote of who supports what? So who supports Dr. Mamoun in his context, lifestyle modification, stop smoking, exercise, and if it's proximal iliac disease, consider revascularization. Otherwise, Dr. Hazem's notion of anybody who has an artery which has a block in it, open it up. So shall we have a vote on who supports Dr. Mamoun? And who supports Dr. Hazem? His team, obviously. I think it's an equal draw between the two contexts. Thank you very much, both of you. Very nice talks. So we go for the next talk.
Next talk will be by Dr. Bashar Ghosheh, is consultant vascular and endovascular surgeon. He will talk about aneurysmal degeneration of aortic dissection.
Well, thank you all for sticking with me. I guess I'm very lucky to be the last session of the day, but we'll try to wrap up this very exciting conference, and thank you for inviting us and being part of your conference. So what I'm presenting today is a multi-specialty approach for a patient who presented from a different country. He was said to have a simple aortic aneurysm, and he just needs an endo repair, a straight shot when you have the conversation from outside. He has hypertension, he has coronary artery disease, previous stent 6 years ago, he has type 2 diabetes, and he has acute and type of chronic renal failure, and turns out to having some back pain. I thought, you know what, this is not a big deal. Dr. Mahmoud, I was lucky that Dr. Mahmoud Zriq actually admitted the patient, and he got a CAT scan, and this is his CAT scan. As you can see, a simple aneurysm. Nothing to worry about. So when I saw that aortic arch, my first response to Dr. Zreikh is that I don't want to touch this patient. This is your patient. You deal with it. But let's get Dr. Walid Damis' opinion about it, because his aortic arch is all dissected and looks horrible, actually. My thought is, where am I going to land that landing zone? This is not going to work. We have to fix his aortic arch first, and then we can fix his descending thoracic part. And as you can see in the CT scan, is that his aorta is also dissected distally also. And I was worried about the celiac, the SMA, the renals, his kidney's not the best. So all these things are going inside my mind. So this is his reconstruction. And I said, thank you, Dr. Mahmoud, and good luck. We consulted Dr. Walid, and we have this multi-specialty approach. And since once Dr. Walid examined the patient, he said, you know what? He looks very symptomatic from his thoracic part. So if you guys can fix his thoracic part, and he'll deal with the aortic arch later on. And he made a point that his hemoglobin is also 7. And his, if you look at the previous CT, that aneurysm is really very close to that digging into his spine. So this was the discussion pre-op, and we decided, me and Dr. Mahmoud, to take a shot and take him to the cath lab, and Dr. Walid was with us also in the cath lab. So again, what's the priorities, what to do next? So we decided, since he's symptomatic and low hemoglobin, he was optimized, he was transferred some blood and taken to the cath lab semi-urgently, to be honest. So this is what we did. So obviously was not available at that point, but we used the pigtail and verify the true lumen. Again, this is more a dissection case than an aortic aneurysm case. And I'll take an aortic aneurysm case at any point more than a dissection case. Dissection is really awful. This is the second access from the left side also. And we did a 3 Mencio, which is a Medtronic centerline measurement for this patient, and got into the true lumen and verified it. And we got the measurement, so that kind of helped us where our landing zone is. We found a landing zone about 6 to 7 centimeter distal to the left subclavian, and that was our landing zone. And we had to use a 2 stent for this case, and we had to make sure that once we deploy the stent, nothing closes, right? Not the celiac. Sometimes with these dissection cases, the flap changes, and the celiac or SMA or renals can close while you're on the table or post-op. So this is our first stent. The pigtail is in good position. It's deploying. Of course, this sounds like it's forever. And my thought is, I hope Dr. Walid would not take him to the OR emergently if he had a retrograde dissection, or that dissection goes to that ascending and closes that coronary ostium. This is recapturing of the fixation point. And we took another picture. We want to see where that celiac is coming from. And our option is either to partially cover the celiac or just to nail it. And it's a little bit harder because the stent deploys from proximal to distal to nail that celiac. So this is actually deploying. The pigtail is down. Please go faster. And this is the second part, is a tapered stent. And you can see the difference in size between the proximal and the distal. So this is the completion. You can't see the aneurysm. Here I want to see still that celiac is still open, the SMA is still open, the renal is still open. The patient did very well, and the case was done percutaneously. He went home and post-abdomen bar 2, and we thought this is really good what we did. And we left it for Dr. Walid to fix his aortic arch whenever he wants, and he can do whatever he wants to do with him. So case closed, right? So until he starts complaining a couple of days later of abdominal pain. And again, what we worried about is that his celiac and SMA has closed off, something has happened to cause his abdominal pain. So we thought, you know what, let's just get a post-op CT scan and know what's going on. So this is his post-op CT scan. Again, very nice aortic arch dissection. This is the stent graft. We were lucky there's no flow into that aneurysm case. So that's the celiac. I guess it was gases. So the patient did well still. And it was still a happy ending. And this is the pre and this is the post for that patient. And thank you.